taking time to be here. I'm Michele Pompano. I'm the educator in the Childbirth Center. We're going to talk about how to care for the pregnant patient that's in the ED. Okay, so what we're going to go through today is the policy. We're going to talk about the outpatient record. That's that triage form that you guys use. We'll go through some OB emergencies, how you manage them. We'll talk about assessing fetal heart sounds, review a little OB terminology, and then we'll finish with a case study. So this is right from the policy. That's the title of the policy. It's in the internet. Jessica did put it under the ED policies. So the process should start with the triage RN evaluating the pregnant patient. They're going to use the 409 form. Is that what you guys call it? The 409 form, or we call it something specific?
The OB form.
The OB form. Okay. We call it the triage record. So you evaluate the patient, then you call the nurse in the childbirth center. You tell them what's happening, and then you guys make a plan together where the best place for this patient's treatment would be. Then the triage nurse tells the ED doc or whoever you guys report to, and then you make your recommendation. It's all right. So then you make your recommendation to the ED physician, and then you guys decide where the best place is. I have to say that everyone's been really good about calling the childbirth center. I feel like we're getting calls all the time. You guys get a lot of pregnant patients coming through the ED, but we appreciate you guys calling. It's definitely steps in the right direction. So these are also right from the policy. These are instances in which the ED doc must call the patient's OB. If the patient comes in and they don't have a doctor, or they come in and their doctor doesn't have privileges here, then they need to be seen by our clinic OB. And so all of our OB docs, they cover for 1 month at a time. So we can, tell you whoever that person is that's on call. So these are issues that would warrant a phone call to the OB. And then if the ED physician and OB determine that the patient's condition is not pregnancy related and the fetus is not in jeopardy, then the patient should stay in ED for care. There is a lot of gray area when trying to figure out where these patients should be, especially because a issue like hypertension may or may not be related to the patient's pregnancy depending on their gestation, for example. Something that we always like to consider when we're getting a report from you guys is this patient sick? Do they have something that they can expose our newborns to? So when you guys tell us this patient is nausea, vomiting, diarrhea, even though they're 39 weeks, and they might also have something that we want to check them out for, we'd rather them stay in the ED. And we can come to you guys and we can bring our machines down and we can come help you triage. So you guys know what this form looks like. So it's important to use this form as a tool to really guide your assessment and really figure out the best place for the patient. The EDC is the most important question you can ask. This is their due date. If they don't know their due date, ask them when their last menstrual period is, and then we can calculate their gestational age. Gestational age is the embryonic or fetal age plus 2 weeks. So this is approximate duration since woman's last menstrual period. This basically just tells us how old the baby is. But we need this information to determine the best place for this patient, obviously. So you guys have wheels in the ED. Mm-hmm. They're very easy to use, but you need to know either their EDC or their LNP. For their EDC, you turn the center part of the wheel until the 40th point of their due date, and then you go to today's date, and then that tells you the gestational age. And then if that's too tricky, there's always an app for everything. And this is free and easy. So we care so much about gestational age because it allows us to care for the baby appropriately. So less than 24 weeks is not considered a viable fetus. Preterm is 24 to 35 weeks. Late preterm, 36, 37. Term is 38 to 42, and postterm is beyond 42 weeks. So we only have a level 1 nursery. So that means it's basically a well nursery. It's not fully staffed. We don't have pediatricians in-house all the time. We really just have a PA in-house from 7 to 3, and then we have one on call. So anything, any issues that arise, we transfer out the babies, and we try not to deliver before 36 weeks, because that's considered preterm, and then they're at risk for many long and short-term complications. If you guys called us and you said the patient says she's 6 months pregnant, that doesn't mean that much to us, because does that mean that they're 20 weeks or 25 weeks? 20 weeks means that they would probably stay in the ED if they had an issue like cramping or bleeding. If they were 25 weeks, we would start to consider a transfer. So it's really critical to know exactly when their due date is. So stillbirths and miscarriage. A stillbirth is a fetal death beyond the age of viability, so beyond 24 weeks, and then a miscarriage is anything before them. Beyond 20 weeks, a burial is required, and then less than 20 weeks, the parents can choose. Either way, the fetus is put into the white specimen bucket without formalin in case genetic studies need to take place. And then you send it to the lab as a pathology specimen, and then just call the lab and tell them.
Where do you get the buckets from the lab?
Yeah, you call them and you tell them, and then that way it's important for them to know what's coming down anyway.
So the white bucket does the matter of weeks matter, whether it's over 20 or less than 20 for use of the bucket?
Well, that's going to be a judgment call. I mean, if you guys had to have a stillbirth in the ED, I mean, obviously it would be something that would happen suddenly. It probably wouldn't be able to fit into a white bucket like that, and then, you know, it could just be any bucket, and they'd have to decide what to do with it then. That would be a judgment call on how big the specimen is. Does that make sense? There's also a stillborn certificate policy, and that's kind of a checklist of what to do. But we wouldn't expect you guys to know everything on the policy. You just call us, and we can come and help you. Especially if it is a stillbirth or an older baby, or a baby that's 20 weeks that looks formed. You know, we want to help you guys. We want to help the patients with that experience. There's different things that we can do to help you know, the families as far as footprints goes and handprints and taking pictures if they choose to do that. And sometimes it is more appropriate for that to take place in the ED. Sometimes it, you know, they can come up to the childbirth center. It's a case-by-case situation. But we are here to help you. So if you guys are concerned at any point, you know, you just call us. Gravida para. So gravida is how many times the patient has been pregnant. Para is how many delivers after 24 weeks they've had. So a G2P1 is a pregnant patient who already has one child. A G2P0 is a pregnant patient who has either had a miscarriage or an abortion. We always want to ask what number of pregnancy this is, because someone might come in and they might say, I'm having my first child, but it might be their third pregnancy, and the first two were preterm deliveries at 18 weeks. That puts her at a greater risk for having that happen again. So it's important to ask what number of pregnancy is this for you. And then what else to ask? So these questions are what we ask any pregnant patient that comes to our floor, that we triage. Are you having any contractions? Are you having vaginal bleeding? Are you leaking fluid? Do you think your water broke? And for patients greater than 20 weeks, are you feeling the baby move? Ask them if they've had any complications with this pregnancy or previous pregnancy, and if the patient has had a delivery, was it by a C-section? So a patient who has had a complication during this pregnancy or a previous pregnancy may be at risk for having that same complication again. So, like I said, if it were preterm delivery, if they've had a history of preterm deliveries, they're more likely to have preterm delivery again or preterm labor. If the patient has a history of a C-section, they're most likely going to be scheduled for another C-section, so that's also important information to know. We'll talk about some complications later, but if a patient has had 5 C-sections, she's probably going to have another C-section. And if she's contracting and she's in labor, then she's more at risk for a uterine rupture. And we'll go through this again, but that information is critical, because you calling us and telling us, I have a patient here, she's term, she's definitely in labor, she's contracting, she's uncomfortable, this is going to be her 5th C-section, we're going to want to open the OR. We don't want anything to happen. And those 5 minutes that it might take for her to get here, she could rupture. I mean, if any of you guys have ever called one of the nurses, we always say, is she bleeding? Did she break her water? And it's hard to remember all of them, but try to get into the habit of asking those questions because they tell us a lot. These are situations in which we would transfer the mom. This is right from the policy. So obviously anything less than 36 weeks and the patient's in labor and they have enough time that we can transfer them. If they're here and they're in obvious labor and they're only 35 weeks, we'll deliver them. That's not an issue. Known anomalies that would require tertiary care if the mom knows that the baby has a cardiac issue or something of that nature. Severe RH sensitization. So that is when mom has negative blood, baby has positive blood, and mom doesn't receive ROGAM during the pregnancy or after the pregnancy. So during labor and delivery, the fetal blood transfers into the mom's bloodstream. Mom creates antibodies to the baby's blood, and then we give them ROGAM, and then the ROGAM prevents those antibodies from happening. So if mom never gets ROGAM, the mom has an antibody still to combat the baby's blood. So this can cause many issues, like as simple as jaundice, but it can cause issues as severe as fetal death. So if a patient comes in and we know that they have this, then we would want to transfer them. Some placenta anomalies, we'll go through those in a few slides. Monozygotic twin gestations, that's identical twins. If twins share a placenta or an amniotic sac, they're more at risk for complications, and we try not to deliver them here. Patient has a BMI greater than 50 and any known maternal conditions. So we'll move on to some OB complications. So an ectopic pregnancy. So this is when a fertilized egg attaches itself somewhere outside of the uterus. So a patient usually presents with sharp stabbing pain. It may be intermittent, it may be constant. It's usually in her belly. She may or may not have vaginal bleeding, and then she may have GI symptoms, weakness, dizziness, or fainting spells. Risk factors, maternal age over 35, smoking, and then anything else that can really cause scar tissue. So a previous ectopic pregnancy, PID, several induced abortions, endometriosis, fertility treatment, or previous pelvic or abdominal surgery. So if you suspect that this is going on, you want to obtain HCG and progesterone levels. These patients will have positive pregnancy tests because they do have a pregnancy, but their levels will be lower than normal. And then an ultrasound will help figure out where the pregnancy is. So there's two treatments for this. One is methotrexate. That is an injection, and what that does is it stops the rapidly dividing cells that are placental cells and embryonic cells and fetal cells. And then they either get that as a single shot, or sometimes it takes multiple doses. If they get multiple doses and the pregnancy is still there, then they would require surgery. Because these cells divide so rapidly and grow so quickly, they're at a great risk to rupture. So if this pregnancy is in the tube or anywhere really outside of the uterus and it's growing, it can rupture. And when that ruptures, the patient's going to fill with blood, and then you could cause permanent damage to any of the reproductive organs, which then creates problems for future pregnancies. These are placental anomalies. So accreta, increta, and percreta. These are high-risk issues. So an accreta, the placenta grows into the wall of the uterus. The increta, it goes through the muscle wall of the uterus. And a percreta, it goes through the uterus and can even touch nearby organs. So these three issues, we don't deliver these patients here. They're high risk. You don't need to know the difference between them, but it's important to know that that's not normal, and we don't deliver those patients here. An abruption is something different. This is when the placenta tears away from the inner wall of the uterus, either partially or completely. So a patient may come into the ED presenting with a placental abruption, abdominal pain, tenderness. They may or may not be bleeding. So these are kind of hard to identify. The only real way we can kind of tell what's going on is by putting them on the monitor. But that's just your nursing judgment you got to use to know that this patient, is in acute pain and there's something else going on. There's really no other way to tell. A patient who may be abrupting, if they're an illicit drug user, they're more at risk for an abruption. Uterine rupture, I talked about this a little bit. This is when there's a tear in the wall of the uterus. So sudden onset of abdominal pain, bleeding, fetal distress, we only know that if the patient's on the monitor and we can see the fetal heart rate. And then in serious cases, protrusion of the fetus or placenta into the abdominal cavity. So patients who've had a previous C-section or multiple C-sections are at a risk. If they have a large baby, if mom is short, or if they have a post-term delivery. So that's beyond 42 weeks. So the only thing that we can really do is an emergency section, and then the docs can try to repair the uterus, and if they can't, they'll do a hysterectomy. So a patient who's had multiple C-sections, again, this is why it's important to find out that information, because we actually had one of these not that long ago, and it was best case scenario because we were doing the C-section anyway, and then once we started, we saw that she was starting to have, and she started to rupture her uterus. So time really is of the essence, and if this patient ended up going home instead of doing the C-section, it really could have been a bad outcome. Okay, a cord prolapse. So this is when the umbilical cord comes through the cervix, ahead of or alongside the presenting fetal part. So we're able to tell if this is happening if we see decelerations in the fetal heart rate on the monitor. How you guys would tell that this is happening is if you saw a cord in between the patient's legs. Risk factors are if they've ruptured their water. Polyhydramnios, that's if they have an increased amount of fluid. If they have multiple pregnancies, so twins, triplets, breech presentation, and a long umbilical cord. What you do is you put the patient in hands and knees, you elevate the presenting part, give them oxygen, and then you have to do a C-section right away. So the cord is going to the baby, it's giving the baby oxygen, it's giving the baby blood, and now the head or the butt or the hand or whatever's compressing against that cord is preventing all that oxygenation and perfusion. So it's important to flip the patient and then use gravity to kind of pull the baby back towards like the mom's head, and then you have to put your hand in through the cervix and then lift up the head or whatever's there. This actually happens in the ED, the other hospital I work at, and the patient came in with the cord hanging down to their knee, and the ED nurses knew what to do. Put the patient hands and knees. One of the nurses put her hand up and she elevated the head, and she said she knew the baby was doing okay because she felt the baby's hand squeezing her finger. So, and then she took a ride up to our unit, and we had a great outcome. So this is something that could really happen. So a precipitous labor, precipitous delivery, a rapid labor progression, and or immediate delivery. Patients who are at risk for this, multiparous mom, so if it's their mom, if it's her 4th, 5th, 6th baby, they have a history of rapid deliveries and illicit drug use. So you call us, you get your delivery tote, which I have, I'm going to open it up, and you want to get IV access for mom. Patients who deliver quickly are more at risk for a postpartum hemorrhage, so at least getting IV access is critical, so in case we need to give blood, we can. So we'll go through this. So the most important thing to remember if you guys have a delivery down in the ED is the baby's going to come out, and the baby's probably going to come out quickly. You put the baby right on the mom's chest, and you dry and you stimulate the baby with towels, blankets. There's one blanket in this tote, it's all the way at the bottom. Skin-to-skin contact between mom and baby helps the baby's transition really well. It helps them regulate their blood sugar, regulate their heart rate, regulate their respiratory rate, and regulates their temperature. So the baby comes out, right on mom, dry, stimulate the baby. And then the only things you really need are in this delivery kit. In here you have a couple things in here, but the most important are 2 Kellys and a pair of scissors. And then there's also a pair of scissors out here. So baby comes out, the doctor is going to want to cut the cord. So you need 2 Kellys and you clamp, and you cut the middle. Okay. So now the baby has the cord, a long cord hanging off of them with a Kelly on the end, and the placenta still inside with the cord hanging out with the clamp on the end. Okay. Then we use a little yellow cord clamp and just put it a little bit closer to the baby just in case the Kelly falls off. We don't want the baby to bleed out. So this is like a little insurance. And then the placenta can take up to 30 minutes to be delivered. So by that time we're down there or someone's down there to deliver the placenta. But that's really it. I mean, you guys also have down here the name tags and stuff. And that's it. Your gloves. You have the EKG leads. So if we bring down the monitor, we're able to hook the baby up to it. But the most important thing is just keep mom and baby together. Like 90% of deliveries the babies have good transitions, and it's because they're skin to skin with mom. All right, preeclampsia. This is another thing that you guys have probably see more of in the ED. It's a disorder of widespread vascular endothelial malfunction and vasospasm. Blood pressure greater than 140/90 and protein in the urine. So we do a protein creatinine ratio on most of our patients with suspected preeclampsia. Do you guys do dipsticks or no? Okay. And then they also may have other issues like low platelets, their liver functions may be off, renal insufficiency, pulmonary edema, visual disturbances, and I'll go through some more signs and symptoms. Presentation, high blood pressure, protein in the urine, severe headaches, visual disturbances. A lot of times they say they see floaters. Epigastric pain, sometimes they say it feels like heartburn. Clonus, if you dorsiflex their foot back and then it spasms back into normal position, that is indicative of an increased risk for a seizure. That's a symptom. Nausea, vomiting, decreased urine output, and edema in the face and hands. Got cut off there. Risk factors, African Americans are more at risk. Primates, so people who are having their first baby or just had their first baby. Women over 40, if they have a family history, and if they have an elevated BMI. It can be hard to diagnose this with a pregnant patient because a lot of times some of these symptoms can be pregnancy related. Most pregnant women at the end of their pregnancy are swollen. They do have headaches. They do have heartburn. These are all normal pregnancy symptoms, but the diagnostic references are high blood pressure and the protein in the urine. Anything else is just ancillary, and it just really proves that preeclampsia is the diagnosis. I'm not sure if you guys use this order set ever, but if you suspect preeclampsia in a patient, you can order a mild preeclampsia panel, and you would also want to order a urine protein creatinine ratio. So all those things are in the mild panel. You get a CBC, you check your liver functions, uric acid, and usually just the clean catch is fine. If this patient is postpartum, they may want to do a straight cath because you're going to have blood in your urine for a postpartum patient.
What's TR?
Deep tendon reflexes. So if you're suspecting preeclampsia, the patient would need an IV, they need a Foley, they'll be on seizure precautions, and then you start to consider your medications, which I'll talk about more at length, magnesium, labetalol, nifedipine, hydralazine. So you monitor vital signs, you monitor breath sounds, O2 sat, your deep tendon reflexes. So you check reflexes because preeclampsia changes your cortex and it can alter your equilibrium. which results in an irritable cortex, and then it can cause hyperreflexia, which is a sign of preeclampsia. And then you assess for clonus, level of consciousness, and then they're on strict INOs. They're at a greater risk for fluid overload, so you really don't want to give these patients too much fluid. So I'm going to talk more about preeclampsia, but I want to touch on HELP. So HELP is preeclampsia in a more severe form. So 10 to 20% of women that have preeclampsia will develop HELP. Okay, HELP is worse than preeclampsia. It's all the same symptoms of preeclampsia, and then you also have low platelets and then hemolysis. Same interventions follow, except these patients are at a greater risk for bleeding because they have low platelets, and then we would consider platelet transfusion or blood transfusion for them. We transfer out patients that are going into HELP syndrome. They're high risk. Magnesium is a short-term medication. We only use it for about 48 hours or so. Magnesium is not going to help bring down the blood pressure. It's just going to help depress the central nervous system, relax the patient. It may lower the blood pressure, but the goal of MAG is neuroprotection. It's to prevent seizures from happening. So on top of the MAG, you may also need medications to help lower the blood pressure. So before initiating magnesium, you get your vital signs, breath sounds, O2 sat, neuro check, DTRs, you assess for clonus, level of consciousness, and then you give a loading dose. So it's usually 4 or a 6 gram bolus. It's over 15 to 20 minutes, and you can't bolus it from the maintenance bag. We have separate bags that are either 4 or 6 gram boluses. Obviously, you monitor for any adverse reaction, and you initiate seizure precautions. Then after that goes in, they get a maintenance dose. It's 1 to 3 grams an hour. It's most typically 2 grams an hour, and then LR is infused with it. Again, you monitor for fluid overload. Typically, you don't exceed 100 to 125 mLs an hour. Okay, so usually we have a 40 gram bag of the MAG in a liter, and that goes in over 50. That goes in 50 mLs an hour, and then your LR is either 50 or 75. So you're really not getting all that much fluid. And then IV calcium gluconate is the antidote for MAG toxicity. It's very rare that in a healthy pregnant patient that their body wouldn't be able to filter out the magnesium, but in case, then you give the IV calcium gluconate. Symptoms of toxicity include somnolence, absent deep tendon reflexes, hypotension, bradycardia, and a respiratory rate of less than 16. You also want to always have 2 nurses double check the magnesium before you give it, because it is a high alert medication. And just as a side note, we do give magnesium for preterm patients. It depresses the central nervous system, so we give it to hopefully slow down the contractions and prolong labor before we transfer out a preterm patient. So these are medications. This is not a protocol or anything, but this is an algorithm that we generally just end up following, but just so you're familiar with the medications that can be given to pregnant patients. Hydralazine, labetalol, or nifedipine. It is important to know that these babies are used to living at these high blood pressures. So they're stressed, but they can deal with these 150s over 100s. If you give these moms a ton of meds and blood pressure drops rapidly, then the babies are going to experience distress, because now they have to adjust to this new pressure. If you give these meds, you really want mom on a cardiac monitor. And if you're going to have to give these meds, we should come down and put the patient on the monitor, because if the baby experiences distress from these meds, we have our own intrauterine resuscitation measures that we can provide. Okay, so if you have to give these, then you really should have us there with you to help.
At what point would you transfer the patient to the child person?
Well, that depends on how stable the patient is. I mean, I've heard many stories of you guys initiating the MAG, in the ED and then transferring the patient out from the ED. I think as soon as the patient is stable enough to transfer to us, you'd want to get them to us as soon as possible. But it's not unlikely that you may have to start the mag and then give the beta-well while the magnesium bolus is infusing. It's probably less likely that you need to start the maintenance dose, but starting the bolus, I've heard of you guys doing that
But
frequently.
if they're less than 36 weeks, then we should be anticipating
Correct.
transferring out,
Correct, right
not
from the
to
ED.
CBC.
Yeah. Postpartum hemorrhage. This can also occur up to 6 weeks after delivery. The patient may complain of heavy bleeding. She may have symptoms of hypovolemia. These are the 4 risk factors that we talk about in OB that are related to labor and delivery. So tone, tissue, trauma, and thrombin. Tone, a patient is more at risk if they have a larger baby or more than one baby in their belly because their uterus is getting overdistended. If they have a quick or a long labor, and then if any medications are used, they're at a greater risk. Retained placenta, that's probably one of the higher risks of a delayed hemorrhage. A lot of times the placenta comes out and a piece may be left in, and then that might trickle bleed, or it might just start bleeding profusely in a few weeks. Lacerations, hematoma, instrument delivery, and any coagulation defects or suspicion of sepsis. You guys don't need to remember all that. Just ask them, if they come in, they're bleeding, they have symptoms of hypovolemia. Did you have any issues during your labor or delivery? Were there any complications? Some of them probably don't have any, but a lot of them probably did have an issue or one of these risk factors that would cause the hemorrhage thereafter. So what do you do if a patient is hemorrhaging? You lower the head of the bed, you get their vital signs, you give them oxygen, and then you just make sure that they have adequate IV access to 18 gauge IVs. Just prepare for blood. And then you want to find out what's causing the bleed. These are medications that we give up on our floor that we have access to if a patient needed it to stop or slow the bleeding. We also have the Bakri balloon it provides pressure on the cervix to mechanically stop the bleeding, and then if bleeding persists, then they have to move to the OR to find out why the patient's bleeding. The first thing is to fix the cause of the problem. Like I said, many times a delayed hemorrhage is a retained placenta, and sometimes the doctor can go up and scoop it out with their hand, or sometimes they need to go to the OR to do that. So you want the patient in the semi-Fowler's position. You have your Doppler, you put gel on your Doppler, and then you first start by looking in between their belly button and then their pubic symphysis. So a patient that's just pregnant, just found out they're pregnant 10 weeks, their uterus is still in between their hip bones. It's still very, very low in their pelvis. Then as the patient gets more pregnant and the gestation progresses, the uterus gets larger and larger, and then by 40 weeks, it's up above the belly button. So early pregnancies really have to look very, very low. And then sometimes just angling the Doppler can help find the fetal heart. You always want to put the pulse ox on mom, because sometimes if you're very low like that, you can pick up the mom's femoral artery. And then a little tip, if you're having issues, then just go quadrant by quadrant. You can find the baby's heartbeat best through the fetal back. So if you put your hands on the mom's belly, if the mom is, 20 weeks and beyond, and you know that there's a baby in there and you can feel the baby, put your hands on the belly and try to figure out where the baby is. At least just get yourself a little more comfortable with, feeling her abdomen, feeling for tenderness, and assessing her a little bit more. And then just try to do quadrant by quadrant. You can usually get a Doppler around 12 weeks. Not always. If a patient is larger, it's more difficult to find the fetal heart, in which case you just need to do an ultrasound. Usually, do you guys have a digital, or you just hear it? Does it tell you the number? It tells you the number. Okay, good. Earlier in pregnancy, it's higher, like 160s. and then it settles between 110 and 160. So anything in that range, it's a wide range, is normal. And it's normal for it to go up and down. As the baby gets older, the fetal heart will increase with fetal movement and then come back down. That's good. That variability tells us that the baby's getting oxygen, so that's normal.
Is there a length of time you're supposed to listen for? Is it?
You really just want to listen for like 6 seconds. And then if you don't get the numbers, someone once told me that you didn't have a digital.
We just got it.
You did? Oh, okay.
Just like yours.
That's good. Because if you didn't have a digital, you listen for 6 seconds and then you multiply it by 10, 100. And then that tells you the 10, 60 seconds. Yeah. It's tricky and it takes practice. And I know, we want to help you guys, and if you can't get it, that's fine. We'll come and help you, but we want to show you how you can try. And getting a fetal heart on a 12-weeker is so different than getting one on a 40-weeker, and it just takes some practice. So just so you guys are aware, an NST, that's something that we do. It checks the fetal well-being. It measures the fetal heart rate in response to fetal movement over time. So it's called a non-stress test because no stress is placed on the infant. It's just testing their well-being over a period of time. We do them after 26 weeks. We have portable monitors, so we can bring our monitor down to you guys. It takes about 20 to 30 minutes. And then we stay there the whole time to assess the fetal heart rate.
If we're going to transfer anybody out, the receiving facility will want to know if we did this. So we really do want to call CBC and have them come down with their stuff to do it.
Which makes sense, because if the patient's that critical that we need to transfer, if the patient were preeclamptic or you're giving medications, you have 2 patients. You have a mom and a baby, so we want to know that you're not giving anything to the mom that's going to impact the baby. So our ability to assess the fetal status while everything else is going on is important. Okay. So we'll do a case study. All right, you have a 35-year-old, apparently pregnant woman. She comes to the ED. She's complaining of 10 hours of 4 out of 10 regular period-like pelvic cramping. It radiates to her lower back. She also complains of 8 out of 10 throbbing headache accompanied with blurred vision. Past history is unremarkable. No medications, no allergies. These are her vitals. So what other information do you need? What would you ask her? She's apparently pregnant, yeah.
So that means she is pregnant.
Mm-hmm.
I'm pregnant.
Someone's last period.
Yep, or when's your due date?
First number of pregnancy.
Good, yep.
Check the urine for protein.
Yep, so that would be one of the labs you would order.
Any problems with the pregnancy?
Yep.
Any like vaginal bleeding?
Bleeding, leakage of fluid. And then if this was her second pregnancy, her mode of delivery. So if she had a vaginal or if she had a C-section. So what labs would you now consider?
Mild preeclampsia, PMO, vaginal.
Yeah, that's everything. So that'll even prompt you for a UA, that panel, but then you would have to add on the protein creatinine ratio. Okay, so now you have a little more information. She, according to her LMP, she's 30 and 1. This is her second pregnancy. She delivered her first child at 32 weeks via C-section. She's had no prenatal care. She denies bleeding or leakage of fluid. Her CBC is normal, but she's got protein in her urine. She's got elevated AST, ALT, and she's got an elevated protein creatinine ratio. So now what are you thinking?
What is 30 and 1 7 weeks?
So that's her gestation. So that means she's 30 weeks and 1 day.
Okay.
So that's preterm. That's in that 24 to 36 range.
Why
So-
hasn't she had prenatal care?
We ask patients that all the time. We never get an answer. We'll never know.
They didn't know they were pregnant.
Yeah,
Yeah.
that's right.
Yeah. Some people are afraid of doctors. We hear a lot of reasons. So what do you think?
Preeclampsia.
So because she's preterm, we're thinking that she probably needs to be transferred, right? So she's high risk. You've already called us and we're helping you. So you're going to consider a mag bolus and then an infusion. consider labetalol, hydralazine, nifedipine, and then just something for your knowledge bank, betamethasone IM. That helps with fetal lung maturity. So it's a steroid. We give it to preterm patients. We actually give it all the way up to 37 weeks now. We give one dose. We give 2 doses. Each one is 24 hours apart, and it helps speed up that fetal lung maturity. So if they're going to have a preterm delivery, the baby has a better respiratory outcome, really. So now your patient's on MAG. So now what do you have to assess? How do you do it? You just have to lift their leg up off of the bed a little bit, and then you hit right here, and then it's scaled on +1, +2, +3, +4. So normal people have a reflex of like +2, maybe +3. That's a normal reflex, and then +4 would be hyperreflexia, and that's a symptom of preeclampsia. It's also important to know though, because if a patient has MAG toxicity, they have no deep tendon reflexes. So that patients that are MAG toxic are they're very somnolent. They can barely speak. They can barely lift their arms. It's a serious myth. That's why it's important to assess.
If you had a pregnant patient laying in the
Yeah,
bed,
so you have them laying
lift
down
it,
and you lift their leg.
leg up in the air.
Yeah, you just I rest it on my arm like this, and then just hit right here and see. You can also check the arms too. I always have a hard time with the arms. The legs are usually a little easier, but it's important to check that. What else do we need to check? Yep. Yep. And then what does she need if she's getting MAG and then she has LR going too? What else? Yes, yeah. Well, she'll have the MAG going and LR going, so she needs a Foley catheter. So eyes and nose are important, so we definitely need a catheter. So overall goals, we just want to improve collaborative care between ED and CBC. We want to provide the best, safest, most appropriate care to our pregnant patients. We want to help you guys. If you have any questions ever, just call us or you can call me.